The topic given to me today is a community health outreach, rhetoric to reality. So in simple words, what is community health outreach? It is nothing but just the care of underserved populations. And indeed, in Indian healthcare system, the care of underserved populations is the most compelling challenge we are facing today. And I have a first-hand experience of working with these underserved populations in remote and rural areas of Himachal Pradesh, one of the northern hilly states of India. In fact, just a minute. I started a Build Healthy India movement, a non-profit and a voluntary community health outreach program, which I'm running for last 2 decades. And I worked around 13 years in different villages, remote villages of Himachal Pradesh. So in today's lecture, I'm going to share with you some valuable insights I had while working at the grassroots level. So let me start my presentation. To understand my presentation, I am just sharing with you what is the normal career path of a typical doctor in Indian Healthcare Institute in the healthcare system. So I'll be using some recent data given by National Medical Commission and also by WHO. If you see, last year, 15 lakh students appeared in NEET. Same year, around 85,000 undergraduates got their MBBS degrees from total of 562 medical colleges in India. Nearly 50% of them are private medical colleges. Another 43,000 postgraduate students got their MD and MS. And around 2,500 medical doctors cleared their super specializations, MCH, DM, and PDCC. Now, all these medical professionals add to the existing pool of doctors, and currently India has 1.2 million registered medical doctors. But this is a stock of medical doctors, and all of them are not actively practicing. 30% of this stock is out of active labor force. Either they have migrated abroad, or they have switched the professions, or they have retired, or they are dead, or they are simply unemployed. Which I'm coming into this category for last 2 days after 2 years after the COVID has started. I'm also a little out of active labor force. But 70% of the doctors, they are employed in the Indian healthcare system. And out of them, only 10% are in government jobs, whereas 90% are doing private jobs, which include non-profit sector also. So these figures may be varying by plus minus 5% depending upon the source of data. But most interesting is that most of these doctors, 3/4 of these doctors are working in urban areas, which are just a 30% of population. And unfortunately, only 1/4 of the doctors go to rural areas. And now I will overlap my own career journey as a medical doctor. So I cleared my MBBS, then MD Pediatrics from PGI, then PDCC from SG PGI. And then there was a U-turn in my career. I decided to join in a rural sector. Initially, few years I worked in a government setup. Then I navigated a middle path of non-profit working as a volunteer. And I spent nearly, around 13 years in the remote villages. And one fact I will like to highlight you, when I worked there in the villages for nearly 13 years, I was the only qualified MD pediatrician in the whole district, including the district hospitals. So such was the scarcity of especially the specialist doctors in the rural areas. Now, why the specialists and the super specialists hesitate to go to rural areas? What are the challenges? Why we don't opt for the community? So when I took this out of the box decision, so what were the challenges I was facing? I'll share with you. Normally, if you go through literature, they say when people want to join community rural areas, so there are many professional difficulties, there are administrative bottlenecks, there are social fear of social isolation, and there may be some serious financial constraints. But lurking beneath all those factors, I feel there are two fundamental fears. And what are those fundamental fears? One is the fear of better options. Short form is FOBO. Another is fear of missing out. That is FOMO. So FOBO and FOMO. So when I wanted to go to communities, people will talk about joining academic institutes. People will talk about going abroad or maybe joining some corporate sector. So all these options are really promising and enterprising as compared to joining and working in a remote community. Another fear is FOMO, that as soon as you want to go to some remote area and start working, the people started, your colleagues, your friends start questioning you that you are committing a professional suicide. You will be isolated professionally. And certainly you have initial fears that you will be lagging behind your colleagues, your contemporaries, and they will be professionally much more advanced when you will be lagging behind. But if you are able to overcome these FOBO and FOMO, then sometimes you can be very fortunate like me to land up in places, beautiful places like these. So these are the pictures of some of the villages where I stayed, where I worked for more than a decade. And some of them my volunteers. And ma'am would notice that I am carrying a rod, which is nothing but a stadiometer rod. So whenever we used to go around different villages, this stadiometer rod served two purposes. One was to help me in measuring the heights of children. And second was, there were lots of bears and leopards around in the villages. So this was a protective gear for me also. So it was serving the dual purpose. Now coming to the rhetoric part of my presentation, to understand the rhetoric behind the community outreach programs, I will be defining what is the basic fundamental role of the doctor. This has been aptly described in a Scottish doctor framework, where a three-circle model developed by the University of Dundee has been given to define the role of doctors. In this three-circle model, the inner circle represents the first role of doctor is doing the right things. And the middle circle represents that second role is doing the things right. So doing the right things and doing the things right semantically appears almost similar, but there is a conceptually a big difference between the two, which I'll just describe. And third most important role is, are you the right person doing the things? Now let me decode these roles so that you understand the concept better. Now, as far as first role is concerned, doing the right things, this may be relevant for all the residents who are participating in today's meeting. During our residency or academic training, we are expected to learn or perform right tasks and right things, whether it is taking history, doing clinical examination. So right history, taking right clinical examination, right way to diagnose, and right way to manage patients. So here, basically what we are aiming at is our technical competencies. And most of this role by the doctors at the stage of MD, MS, or DM is driven by their IQs. So they should have good working memory, logical reasoning, information processing, comprehensions. So IQ is key factor in this role. But after we complete our residency and we join as a consultant or a faculty in a private or a government sector, this second role, doing the things right, become important. So what do you mean by this? Which approach do you adopt to implement whatever skills or competencies you have learned during your training? So when you start doing things right, it means you need to develop a critical thinking, an analytical thinking, and your decision-making competencies should improve. And basically underpinning this role, what matters psychologically is your emotional quotient. So if you can understand yourself better and others better, then probably your decision-making will optimize. So it is being smarter with feelings. So that is why we always go to our faculty, to our consultants, to improve upon our decision-making as residents. But the role which I am interested is this third role of are you a right person doing things? This role becomes important as a professional when you are joining some healthcare delivery systems, particularly from a community or a population point of view. For this role, what we need is our personal competencies. Personal competency means what is your personal development, what are your personal values, and personal intelligence. So personal intelligence means it can be easily defined in psychological terms as social quotient. So you should have a high social quotient to understand, manage, and navigate complex social and community networks. This is very, very challenging. And here I would like to share one secret with you, that I worked for more than 15 years in the villages. And in the hindsight, I now realized that I had a zero social quotient. So I like to repeat so that you are clear that I had a zero social quotient. So then you must be surprised that if I had such a low quotient, how could I survive in the villages for more than 15 years? See, models are models. They may not be true in the real life. But there is a catch. So when I started working in different villages, I was fortunate that the villagers with whom I worked, they had very, very high social quotient. So they understood me well. They understood me that is a young doctor who has come, who has recently passed and has many degrees. So he has a good IQ and reasonable emotional quotient to take decisions. So they understood me, but they appreciate and they could understand that I'm lacking in their social quotients and I'm not understanding their complex social networks. So they extracted best out of me, and I could give them, so I could make an impact on their overall community or the population health. Now, to understand why most of our rhetorics fail in reality, this slide will be important. I will be requesting you to pay little attention. There are two approaches to health which are being followed. One is individual health approach, and second is a population health approach. So with an example, I will try to simplify this difference. Now, suppose there is, I'm going to give an example of hypertension and the risk of stroke or other cerebrovascular accidents in a given population. Now, this curve gives you, this is a normal distribution curve of a hypothetical population where the systolic BP is distributed with a mean value of 120 and standard deviation of 20. So this is the mean value of the systolic BP. So we all know as BP increases above 140, the risk of stroke increases. So this red zone in the tail of distribution is the number of people or the proportion of population with an increased risk of stroke. So if we calculate this area, it comes to 16%. So 16% of the population had increased risk of stroke. Now, people practicing individual health, how do they approach this situation? So when we are working as a clinicians in the hospitals, medical colleges and institutes, so we are focusing on this red zone of population with high risks. So what we will do, we will diagnose them, we will screen them for complications, we will prescribe them treatments, we'll make sure that they adhere to the treatment. So our target as clinicians is to make this group of people normotensive. So what basically, theoretically speaking, we get is a curve like this, which is truncated at the tail. So this is very desirable outcome, but in real life, this is artifactual and unrealistic distribution. We can't achieve this. So now coming to the other approach of population health. So as a part of population health, how do we approach this situation? Instead of focusing on this red area, we focus on the middle of the curve. So you can see with the green area which I marked. So we focus on a much larger middle part of the distribution. These are the population with a much larger number, though exposed to lower risk. Now, why do we use this approach? Why do we ignore the people who are have high risk and falling in a red zone? It is very simple. If by working in the population, we are able to make even modest reduction in the average mean BP of the population, if we can lower it little bit, what we will do is that we will shift the whole distribution curve towards the lower risk as shown in this figure. So if you see this figure, here we lowered the mean BP of the whole population to 100. As we shift the mean BP there, the whole distribution shifts to lower risk, and the number of people falling above 140 becomes automatically reduced to 2.3%. So if we work at the level of population and try to involve the whole population, then probably the need for individual care will also automatically come down. So this reflects, but this is theoretically, this is a theoretical concept, but this is a radical concept. Now, when our policies are made, if we don't consider this concept of population health, we don't absorb this concept of population health in our mainstream policies, many of our policies are likely to fail in reality. And this is what we have seen over the years happening with our healthcare programs. So this was rhetorically, I've explained things, but no, I will be taking you to the reality in the villages, which I have found. Though my experience may not be matching with the experiences of other people who are listening to me, but these are my individual experiences I am honestly presenting to, so you can differ with me also. I will be using a very famous saying, probably given by some author Finnegal. Here, this law has, this saying says, there are 4 components of this saying. What you have, you don't want. What you want, you don't need. What you need, you don't get. And what you get costs more than what you can pay. So using these 4 principles, I am going to show you the various realities happening at the ground level in the communities. So first principle is the healthcare. So I have tailored it to the healthcare, this law. The healthcare villagers have, they don't want. So what do I mean by this statement? If I've taken this picture, this is I've recent data about rural health statistics by Ministry of Health in 2018-19. In rural India, there are more than 1.5 lakh sub-centers, 25,000 primary health centers, and more than 5,000 community health centers. But if you look at the recent data, only 11.5% of households in rural areas seek OPD services below the CSC. So at the sub-centers and PSC, only 11.5% of people are seeking healthcare. And alarmingly, 75% of the outpatient care and 62% of the inpatient care is provided in the villages by the private sector. And I have seen with my personal experience that when we go to primary health centers, sub-centers, we find a lot of ORS packets lying there, iron tablets going waste, oral contraceptive condoms, chlorine tablets. And often healthcare workers in the primary health centers, they are dumping these things in the pits because they have expired. But when I started working, I found all these things as key weapons in my armamentarium to improve the community health. But we had to use very creative ways to improve the utilization of all these things. And one of the creative way which we used to enhance the utilization of iron tablets among the villagers was a strategy which was told to me by one of my illiterate volunteers. One of my volunteers observed me for 1 year and he realized that I have been prescribing iron to most of the people, most of the women coming to me in my OPD. He said, sir, I have seen you for last 1 year. From head to toe, whatever is the problem, you always say that you are anemic and you need iron. I said, this is true because most of your women are anemic. Then he said, sir, if it is so, then you prescribe the treatment, they take the iron tablets, it is free of cost, but when they go home, they just discard it, they throw it out. So they are not taking it. I said, that is also true. So then I asked him, what is the solution to this problem? He said, sir, if it is so important, and then we can go door to door and give supervised iron ourselves. I said, it will be very challenging. He said, I can try it in my own village. So in a village of say 100 houses, we selected 25 houses where there was severe anemia in women. And that my volunteers started going to door morning, evening, selecting some fixed time. And we gave iron for 3 months. And we published this study in Indian Journal of Medical Sciences 2004, and the results were, she was very instrumental. We got a project sponsored by DST, and we carried out the same intervention as a randomized controlled trial, cluster randomized control in 32 villages. Though we carried out the trial in 45 villages, but the full data was available for 32 villages. And we published that trial in Asian Pacific Journal of Public Health in 2015. So what we found that if we give supervised door-to-door home-based daily iron therapy as compared to the unsupervised monthly iron supplementation provided by healthcare centers, we improve the compliance markedly, significantly, tolerance is much better, and the efficacy of eradication of anemia is also much, much better. So these ways, by using creative strategies, we enhance the utilization of iron folic acid tablets. But in the first principle, I will also like to highlight one interesting fact about the villagers' perspective about various healthcare providers which are there in their villages. So how do villagers perceive the healthcare providers? So villagers know there are MBBS doctors and it's surrogates. Surrogate means anybody working in PHC, whether it's a peon, it is a sanitary worker, it is a pharmacist, they are all treated as MBBS doctors. But there are reports from studies carried out in Madhya Pradesh primary health centers that 63% of patient interactions in the PSCs are not occurring with the doctor, MBBS doctor, but the surrogates are treating those patients. The second healthcare providers are basically from alternative streams of medicine, which we collectively call as Ayush, but most of them are Ayurvedic doctors. They are also available in the villages. And third major chunk of healthcare providers are unlicensed or informal practitioners. Earlier, we used to call them quacks or jhola chhap doctors. But this term is no more respectable, and they have some important role to play. Now, when I ask villagers, how do you decide which healthcare provider they will choose? Now, first I'll tell you, how do they define these healthcare providers? They have a very interesting way to define. So for an MBBS doctor, villagers say the MBBS doctor knows everything, but does nothing. And when I ask why, they say he or she is hardly present in the primary health center. And whenever the MBBS doctor comes to primary health center, he's mostly busy with some paperwork, either drawing salaries, making inventories, or making purchases. So he doesn't have time to see patients. Ayush doctors, Ayurvedic doctors, villagers know that they know something, they do something, but in case of emergencies, they refer everything. But as far as unlicensed doctors are concerned, or informal practitioners are concerned, they know nothing, but they will do everything. So this is how the villagers describe. And when I ask them which one do they choose, they again have a very subconsciously, they have developed a very good algorithm to choose among the three. The villagers say that when it is too early to treat, that is, they know this is a small viral illness, some common cold, so they will prefer the unlicensed practitioners because the villagers know he will provide you a very heavy-handed symptomatic treatment, an injection of diclofenac, some injectable antibiotic gentamicin, and a good dose of a cocktail of oral drugs. So the patient will be symptomatically all right within a day. But when it comes to Ayurvedic doctor, they say, sorry for this slide. But for the Ayurvedic doctors, they say, when it is too healthy to treat, it means villagers are aware that Ayurvedic medicines, they have more of a placebo effect, and they are really very handy if the patients have some functional symptoms which are not too risky or not too life-threatening. But when it comes to MBBS doctors, all villagers are clear that when it is too late to treat, always go to the MBBS or the allopathic doctor, because villagers understand the curative potential of our medicines, and that is rightly so. But this was the villagers' perspective about the various healthcare providers. But over the years, I also developed my own perspective of healthcare providers, which I'm going to share with you. As far as MBBS doctors are concerned, I personally call them as healthless care providers in the villages. They are definitely very good care providers. They provide good diagnostic care. They order lots of tests. They provide good therapeutic care, provide good antibiotics, but still they are healthless. The reasons are simple, because they are frequently absent from the village dispensaries and healthcare centers. They fail to develop some local connect with the villagers. They often confront the belief systems of the villagers. So they fail to win the trust of villagers. Hence, they are not able to modify their behaviors, attitudes, or harmful practices. But as far as the informal providers are concerned, the unqualified practitioners are concerned, I call them as careless but health providers. Whatever treatment they give, it's a careless treatment. They give a very heavy dose of antibiotics, analgesics, injectables. So there are risks, acute risks of them. But still they are health providers because they are present in the village 24/7. They are often the first contact point for treatment. They are local, so they respect their belief systems. And because they have won the trust of the villagers, they are able to, if they are guided, they are able to mitigate the harmful practices or myths related with health practices in the villages. So they have definite role to play. And that is why recent government has also trying to train them through a 3 years diploma so that they can be useful in the villages. And that I will approve as on my own experience. Finally, there are faith healers. I call faith healers as helpless because they have nothing to do with medical care, but they are cure providers. I may not be able to give you scientific explanation, but I have observed ample number of times that patients with mental health issues, with substance abuse, sleep disorders, functional pain syndromes, somehow after I have exhausted all my options, they will take care of some faith healer, and after a few months they'll come back and tell that they have been cured. I don't know what mental rearrangement, they do some sort of mental resetting and convince patients that they have been cured. But again, they are contributing usefully to the societal health. So now coming to the second principle, that the healthcare villagers want is not what they need. So this is another challenge which we face when we go to the community. So you all must be aware that intravenous fluids and neurobion injections are the rite of passage. Villagers prefer these two things. Even मेरे साथ मैम एक बड़ा इंटरेस्टिंग हुआ था, मैंने किसी पेशेंट को severe diarrhea को in a community health center, I started giving IV fluids. After the half the bottle has been delivered, the patient called me and requested that kindly give IV fluid in the other arm also. I said, why? He said, because the other arm is also feeling weak. So they have a concept that giving IV fluids will improve their strength. Maybe relevant when there is a dehydration, but this is a myth which is prevalent. Another interesting story I would like to share is when I was working in a government setup in a primary health center, I noticed that there is a sudden spurt of prescription rates for costly anti-rabies vaccines in the month of March and April every year. So when I investigated, I was a little intrigued. So I realized that most of these patients who are having dog bites, they are government employees in nearby villages and towns. And March and April are the closing financial months of the year. So they feign the history of dog bite and they get the prescriptions for costly anti-rabies vaccine, and then procuring a fake bills, they get the reimbursement from the government. So this practice was going on in many villages. So again, this is an unwanted need. And the third unwanted need which we have observed is recently is that everybody is keen to have an antenatal sex determination for the gender of the baby, which is clearly an unwanted need. As far as medication misuse is concerned, this is a major public health issue in India. A recent study published in 2016 showed that in India, there are 348 medicines in the essential drug list. But mind-bogglingly, there are 60,000 to 80,000 brands circulating in the market. So even if you account for various preparations of essential drugs, you cannot have so many brands. It means there are lots of drugs which are unwanted and unregulated drugs which are circulating. And they are indeed, this results in overwhelming workload for the drug regulators also, and prompts people to a growing culture of irrational prescription as well as consumption by the people. 50% of the average family spending in medicine in India is on irrational, unnecessary drugs, and this is far, far more, though the data is not available for a rural person. Now, the third principle is the healthcare they need is not what they can get. This is very true. I think it is self-explanatory. A law given in 1971 is still applicable, that the availability of good medical care tends to vary inversely in proportion to the need for it in the population. So where there is a maximum need, there is a little availability of good medical care. Not only the quantitative aspect, but if you look from a qualitative aspect also, there are problems. See, in primary healthcare center treatment, it is rarely curative because people are not trained to diagnose illnesses and treat them. Most of times it is a symptomatic treatment. But during my experience, I observed unmasked another trend, which is neither curative nor symptomatic, but I call it as splymatic. Suddenly one day, a pharmacist will come to you, you are sitting in the OPD and will whisper in your ear that, sir, this month the iron tablets are going to expire. So kindly prescribe iron tablet to every patient. So no, the patient coming with gastritis, patient coming with diarrhea, patient coming with fever, even if I don't prescribe, they will hand over a big strip of iron tablets. So I call it as a splymatic treatment to finish this splice at time. Other than these quantitative and qualitative issues, there is a genuine scarcity of qualified healthcare workers. This is a WHO figure taken from Global Strategy on Human Health Resources for Health, where they have clearly shown that on x-axis, there are the number of health workers, qualified health workers available for 1,000 population. And on y-axis, the percentage of various sustainable development goal indicators achieved. So as the number of health workers available for 1,000 population increase, there is an exponential increase in the targets achieved. So we cannot deny the role of human resources for health, but this is little unfortunate, though we are coming up and we are maybe able to meet the targets set by WHO, but still we are short of that. Finally, the fourth principle is the healthcare they need costs much more than what they want to pay. So there is a concept of medical poverty trap. The people falling in poverty trap because of their medical illnesses and their treatments. This is very unfortunate. There is a vicious cycle which starts with the word OOPE. It is out-of-pocket expenditure. And recent data shows that out-of-pocket expenditure is 64% of the total health expenditure in India. And when this out-of-pocket expenditure is more, we call it as catastrophic health expenditure, which exceeds 10% of the total annual household income. There are other definitions also. Once a person lands up with catastrophic health expenditure, the person has to sell assets and borrow heavily. So 3% of Indian population is impoverished every year due to medical expenditure. So this leads to further increase in vulnerability and health inequities in the population. And studies have shown that medicines is the single largest contributor of healthcare costs. And I have clearly seen, and you must also be witnessing that no, the prescriptions are not on pharmacological basis, but there are pharmaceutical incentives also, more so in the villages. And the clear distinction between private practice versus pirate practice is getting blurred in villages. So villages are paying a heavy cost for this lowering of morals in our healthcare system. But I will not be so cynical about this. A recent flagship program launched under National Health Mission, which is known as Ayushman Bharat. I am a big fan of this program, though it is still in a rhetoric phase because it was launched in 2018. But there is a universal health insurance scheme for below poverty line families. This could be a game changer, and probably we will be able to minimize the catastrophic health expenditure to zero, which is our SDG goal by 2030. Now, with the two stories, I will be completing my presentation. See, in villages, the medical illnesses have strong social underpinnings. So you cannot clearly distinguish between medical illness and the social issues. This is an interesting story which I will share with you. As we were doing a project on anemia, we were going from village to village. Once, when we reached a village of this lady, which I've shown in the picture, on clinical examination, I found that this lady is having severe anemia. We took her blood samples for hemoglobin, serum ferritin, TIBC, serum iron levels, and transferrin saturation, complete workup. And we started her on iron tablets. And after 3 months, when we visited their village, I was given a there was a festival atmosphere. The crowd has gathered all around me. They garlanded me. They took me to the stage. I was surprised why so much of welcome is being given. I've been visiting that village earlier also. They said, sir, we have a special occasion and you have to listen to her husband's narrative. So I'll tell you in little Hindi so that आप इस बात को थोड़ा और better मैं justify कर सकूं. तो जब दूसरी बार हम गए तो बड़ा वेलकम हुआ हमारा. तो मैं भी बड़ा सरप्राइज था. मैंने कहा बात क्या हो गई है. कहते सर इस लेडी के हस्बैंड आपको एक स्टोरी सुनाएंगे. एंड एवरीबॉडी वाज सिटिंग एंड देयर वाज अ माइक एंड ही गॉट अप एंड स्टार्टेड टेलिंग मी द स्टोरी. कहते सर आपके आने से पहले शी हैड अ हिस्ट्री ऑफ पाइका. तो वो ना शी यूज्ड टू स्क्रैच ऑल द मड वॉल्स इन द हाउस, आउटसाइड द हाउस, इन द फील्ड्स. एंड सो इट वाज बिकमिंग सोशली एम्बैरेसिंग फॉर द हस्बैंड. हस्बैंड को सभी लोग ताना मारते थे कि यार तेरी तूने शादी की है, एक बच्ची से शादी की है, वो हर समय मिट्टी खाती रहती है. तो हस्बैंड वाज एम्बैरेस्ड. तो हस्बैंड यूज्ड टू फाइट विद हर. सो कपल की फाइट केप्ट ऑन इंक्रीजिंग बिकॉज वो मिट्टी खाना नहीं छोड़ रही थी और हस्बैंड गुस्सा कर रहा था. देन वन डे वाइफ डिसाइडेड दैट शी एंटर्ड इन अ डील विद हर हस्बैंड कि आप मुझे सिल्वर के एंकलेट्स और ब्रेसलेट्स ला दो, तो आई विल कन्विंस माई सेल्फ, मैं अपने माइंड को कंट्रोल कर लूंगी कि आई विल नॉट ईट मिट्टी. तो हस्बैंड वॉज ए पुअर लेबरर. ही वेंट टू अ नियर बाय टाउन, स्टार्टेड वर्किंग देयर, और तब तक काम करता रहा जब तक ही हैड इनफ मनी टू बाय दिस सिल्वर एंकलेट्स एंड ब्रेसलेट्स, एंड देन केम बैक एंड गिफ्टेड हिज वाइफ. तो वाइफ ने उसको कंपल्सिव क्रेजिंग तो थी, बट शी देन कंट्रोल्ड हर अर्ज, एंड फॉर फ्यू वीक्स her urge was not there, but she defaulted again after a few weeks. So again the husband was disappointed. Again there were clashes, they were fighting with each other, but she was not able to control her craving. फिर दूसरी बार वाइफ ने ये डील किया कि आप मुझे गोल्डन ईयर रिंग्स ला दो, I will definitely control my mind not to eat clay. मैं मिट्टी नहीं खाऊंगी. So poor husband had no other option because their social life was ruined because of her habit. So again that husband sold his buffalo and borrowed some money and bought these golden earrings. तो उसको golden earrings gift किए. She is wearing those golden earrings, you can see in the picture. So for another few months she was able to control her craving, but then again she defaulted. फिर दोबारा डिफॉल्ट कर गई, दोबारा झगड़े शुरू हो गए. At that time we arrived at their village for the first time. And I diagnosed it as a severe anemia. We took the blood sample, started her on iron. And when we came for follow-up after 3 months of giving iron daily, her anemia was corrected and her pica had gone. So then husband made this statement कि जहाँ पे सिल्वर और सोने जैसे कॉस्टली मेटल से मेरी वाइफ का हैबिट ठीक नहीं हुई, वहाँ डॉक्टर साहब के एक सस्ते से मेटल आयरन से जो फ्रीली अवेलेबल है, her problem has gone. So then for the first time I realized that such a simple medical illness which we see day in and day out in the hospital, all of you are treating, can have such a major ramifications for the social structure of the family. Now with the last story, I will be ending my presentation. This is Gurdasa ji's logic of poor rural health. In this picture you can see I'm standing with me, Dr. Margaret, Dr. John from Australia are there. My daughter is also there. This is the village where I stayed for 5 years. This gentleman in the middle of the picture is Mr. Gurdasa. He was 100 years of age at that time. He was my local mentor. He used to guide me about various rituals, various traditions, various myths in the villages. So one day I just asked him, Gurdasa ji, what is the reason? What do you feel? So I was feeling that the women and children are quite anemic and weak. So I asked him the reason why women and children are disproportionately more having poor health. So he, reflecting thoughtfully for a few minutes, he said, sir, roads are responsible for the poor health of women and children. So I asked him again whether he is making a correct statement. He said, yes, sir, roads are responsible for the poor health of villagers. So initially I ignored it, but then I thought, let me evaluate it critically as a scientific person. So I did a little bit of thought research. So are the roads responsible for the poor health of rural women and children? So this is one of the roads in the villages where I stayed and worked. In that study, which was done by Gurdasa ji, what was the sample size of his study? One person living for 100 years. So the sample size is 100% years of observations. And if you ask any epidemiologist, this would be a really impressive sample size to make valid observations. Then what was the design of study? This gentleman has observed the villages prospectively for 100 years. At the age of 70 years, the roads came in their villages. So if we exclude the childhood period, at least for 50% years, he has observed before roads, and 30% years he has observed after the roads were built. So the design is pre-intervention and post-intervention. And what type of data he showed me, though he could not collect a quantitative data, but he brought out his marriage album, which was he was married around at the age of 20 years. There was a black and white photographs album, but he showed me the pictures of ladies which were there participating in his marriage. And they really appeared stocky and chubby. That was clearly palpable from the photographs. He said, you can go and compare with the women who are recently married or staying in the villages. So there was a palpable gap between the overall general subjective health of the women then and now. So I was a little bit convinced. But no, I had to find a causal reasoning for this, why this is so. Is it just a random chance, or there is some causal association between the roads and the poor health? Then I asked him, what are the reasons? Why do you feel that their roads are crushing the health of the women? So he gave me two very convincing reasons. First, he said, after the roads are built in the villages, the first thing which arrives in their villages is a milk van. And this van siphon off most of the available milk in the house, which disproportionately affect women and children as men try to keep their quota of milk intact. So the women and children are disproportionately compromised in their intake of proteins and calcium, daily calcium. Second reason is, after the roads have been built, the focus of the villagers have shifted from green leafy vegetables to exclusive cash crops, which are ginger, garlic, onion, potatoes. Earlier, since roads were not there, they were not able to transport their crops. So they were growing mostly crops which were required for their daily needs. So they were growing green leafy vegetables. So after the roads came, they shifted to cash crops. So their daily supply of micronutrients was affected. And since females and children require higher dose of micronutrients, so they were disproportionately compromised. So I felt that this man has a reasonably good causal reasoning, and this made me realize that sometimes a good social development, we call roads as the lifeline in villages, but they can have some downsides also, and we need to be alert and make sure that we safeguard our communities with the newer developments. So with a little philosophical slide, I am completing my presentation, that when you opt for a population or a community health, there are three ways you can work in the villages or in the community. Metaphorically speaking, first is you can be like an ostrich. There is a symbolic fact that whenever there is a threat or whenever there is a danger, the ostrich buries its head in the sand. Though it is not scientifically true, but basically this reflects that many people working in the community, they don't want to face the problem and they ignore whatever problems are there. But some people have a peacock mentality. They definitely achieve some milestones, but they have the habit of showcasing them. They flash their achievements, but again, community is not much benefited there, though there are a lot of pomp and show in their achievements. But finally, my role model is this a small beaver. They have a good camaraderie, they have a great team spirit, and they overcome all the challenges to build their houses, and they use that experience for the bigger goal. So there is a beautiful video of 3 minutes. How do weavers build a dam? This is a documentary by BBC. I think this is a mind-opening documentary. This is a homework I'm giving to the residents. They can go and Google it and they can listen to it to understand why if we have to work in the community, we should have a beaver-like mentality. With this, I conclude my presentation. Thank you so much.